Hello everyone, I'm Samir Mhisen. I'm a specialist orthodontist. I will present this lecture entitled Evidence-Based Practice in Dentistry. 3 weeks ago, I have a patient in my clinic, and this patient asked me that which is better, composite filling or amalgam filling? And because I'm orthodontist, I don't have the enough evidence to say which is better. I said to him that I don't know which is better, but I can refer him to a dentist or a specialist dentist to let him know which is better. I will cover in this lecture the definitions of the evidence-based medicine and the evidence-based practice, and I will cover the evidence-based practice elements and evidence-based tips. Evidence-based medicine is the conscientious, explicit, and judicious use of the best evidence in making decisions about the health care, about the care of individual patients. Previously, the health care was based to the expert health care. But now, after emerging the randomized control trial, the healthcare become evidence-based healthcare or evidence-based practice. The evidence-based practice is the medical practice where the clinician is able to evaluate the strength of the evidence and use it in the best clinical practice for the patient sitting in the office. The evidence-based practice elements are three elements. The first one is the best available evidence, the second is resources, and the third is patient characteristics. The first element is the best research evidence. We have a hierarchy of evidence. In the bottom of the evidence, there is expert opinion. The expert opinion is the lower quality evidence. The higher from this, the case report, then the case control studies, then the cohort studies, and the RCTs. The best evidence in the top of the hierarchy of evidence is the systematic reviews and meta-analysis. The guidelines is better than the systematic review because the guidelines is recommendations of systematic reviews. To know the research or to recognize research's design, to recognize the research design, we should recognize the exposure and the intervention. When we have something that we don't have control on it, like accident, if we have accident, we called it exposure, accident exposure. The smoking is called exposure to smoking. The radiation, if there is radiation, this is exposure. But the intervention that this is something we can allocate it, like when we do finite element analysis on cars. This is intervention. When we divide our patient in the clinic to do 2 groups or 3 groups and give every group a different medication, this is called intervention. This is nice outline explain the study designs or the research designs. At the top, we see that exposure assignment. If we allocate exposure or allocate intervention, the studies will be experimental studies. If we didn't allocate intervention or there was exposure, not intervention, we call this observational studies. The observational studies, if don't have comparison group, then it called descriptive study. If the observational studies have comparison group, We called it analytical studies. The analytical studies have three types. The first one is the cross-sectional study. The cross-sectional study have the exposure and the outcome at the same time. If we did the survey, this is called cross-sectional study. If we took cephalometric X-ray for the third or fifth student in dental college, and we classify them for class 1, class 2, class 3, or skeletal discrepancies. This is called cross-sectional study. The case control study, we have the outcome and we search for the exposure. Like if we have a patient with lung cancer and we search for the exposure, we search for the patient who is a smoker or and who isn't smoker. In contrast, the cohort studies. In the cohort studies, we have the exposure, like we have the smoker patients and the non-smoker patient, and we search for the outcome who have lung cancer and who haven't lung cancer, or who have heart accident and who haven't heart accidents. Uh, for the experimental group or experimental studies, if there is random allocation, the study will be randomized control trial. If there is no randomization, the study will be non-randomized control trial. Randomization is a method based on chance alone by which study participants are assigned to treatment group. Randomization minimizes the differences among groups by equally distributing people with particular characteristics among all the trial arms. So the researchers don't know which treatment is better. The second element of the evidence-based practice is the resources. Resources are the skills and infrastructure needed to provide evidence-based practice. Possibility of material, technological, and financial resources, and individual resources. Simple example for resources in orthodontic specialist, like herpest appliance, Frankel appliance, twin block appliance. All those appliances need expert lab, and if we don't have this expert lab, technically the appliance will not be good, will not be effective. So that the expert is very, very important here, and this is from resources in evidence-based medicine. If I don't have the resources, I don't have to do this appliance, I don't have to apply this treatment. I should have the resource to apply the evidence. Patient characteristics include individual characteristics and preferences that influence the compatibility of treatment with a particular patient. When we determine whether a value research evidence is relevant to a particular individual patient, we need to assess patient's comparability with the study. After that, the decision making depends on enabling patients to manage their health care. If we have uncooperated 10 years boy in the clinic, we shouldn't choose the removable appliance. We should go to the fixed appliance. And we always should discuss the treatment options with the patient and his family, his parents. Another example, if we have an uncooperated patient with a removable appliance, we shouldn't think about headgear or face mask or extraoral appliances, because this patient will uh, not wear these appliances. Now I will cover the steps of evidence-based practice. We have 5 steps of the evidence-based practice. The first step is the question. Ask patient-oriented, well-formulated question. Step 2, acquire the best available evidence to answer the question. Step 3, appraise the evidence critically for validity and applicability. Step 4, apply the evidence by engaging in collaborative health decision making. Step 5, analyze the new health practice and adjust practice accordingly. Those are the 5 steps: ask, acquire, appraise, apply, analyze, and adjust. I have problem here. This is 13-year-old female, the chief complaint, tooth emergence problems. We have palatally displaced canine, permanent canine in the maxilla, and we have buccally displaced canine in the right side. In the left side, we have the palatally displaced canine, and we have retained uh, primary canines. So, what is our choice for evidence-based or without evidence-based? We have choices here. We can expose the palatally displaced canine to accelerate the emerging or eruption, its eruption. We can extract the primary canine and wait. We can wait without treatment, and we can use fixed appliances and exposure and everything. To ask a good question, we should follow PICO acronym. PICO PICO have 4 components. P is patient or population or the problem. I, intervention or the exposure. C, comparison, intervention, or comparison, exposure, or the control group. O, the outcome, clinical importance, the outcome, the primary outcome and the secondary outcomes. In our example, the patient or the problem is 13-year-old female, palatally displaced upper canine. The intervention is extraction primary canine. The control, no extraction, and the outcome is upper canine emergence or eruption. To acquire the evidence, I always search in PubMed. In PubMed midline, we can put our words here. Then we have advanced search. We have filters on the left, and we have the search details in the bottom of the page on the right. At the top of the right, we can see the English search and the all search. This from the advanced search in PubMed, we can use Boolean operator like and or except, and we have the search here in the history. We can see that the search results. I have chosen a 3 systematic review from the search. I have 18 search result in English, the 18 research result in English, and from those I have chosen 2 systematic review, because the systematic review is the hierarchy of evidence. If I found a systematic review, why I will search about randomized control trial or cohort studies or case reports? The first systematic review, extraction of primary canines for interceptive orthodontic treatment of palatally displaced permanent canines, systematic review, Naif al-Masoud. The second one, extraction of primary teeth for unerupted palatally displaced permanent canine teeth in children. This systematic review in Cochrane. This is in Cochrane collaboration by Parkin. To appraise evidence, I should appraise main four parts. I should appraise those main four parts in the paper: the clinical question, the methodology, the results, and the applicability. The clinical question, to see what the researcher asked. And I can found this clinical question in their introduction in the last paragraph in the introduction, or in the objective, on their objective or aim. For the methodology, I should search if the methodology is valid or not. If there is a bias, the bias is a systematic error in the methods or in the measuring the results. I should search if there is confounding factors, like different AMP and different groups, and this will lead to different results. I should check the results if they have a different results from other studies, and how they get these results. Then I should go to applicability, and I will decide the applicability from their inclusion criteria and exclusion criteria, and the uh, severity of the malocclusion or severity of disease that they had in the beginning of the study. There is a lot of websites for critical appraisal, like CASP. In CASP, everyone will find a checklist for critical appraisal, and those checklist will be for systematic review, randomized control trial, for cohort studies. You will find a many checklists for every study. There is other critical appraisal tools in ADLD University web page as the same outlined. Uh, you can choose any checklist. You can choose any website to do this. This is easy and available for everyone. Okay, I will appraise my papers, my systematic reviews, by a tool from CEPM web page. Okay. The first question, this tool have four questions. If one question of those was not good or have the unclear or no answer, the website recommend that you cannot have trust in this systematic review. So the first question: are the results of review valid? What question PICO did the systematic review address? In their tool, where I can find the information, the title, abstract, or final paragraph of the introduction should clearly state the question. Okay, I went through this systematic review and found eligibility criteria, because details of that in table 2. In table 2, they wrote randomized inclusion criteria, randomized clinical trial or cohort studies. This is the study design. Evaluate eruption of BDCS after BDCS. This is the outcome. And after interceptive extraction of primary canine, this is the intervention. And they wrote here, displaced palately canine during late mixed dentition stage. Late mixed dentition stage mean at 10 to 12 or 13. The second question is it unlikely that important relevant study were missed? They wrote in the tool we can find that what is the best? The best is the major database like Midline, Cochrane, and Bayes, and this is mentioned in the Cochrane handbook uh, for systematic review. Then they wrote that references list from relevant studies, unpublished studies, grade literature, and search will not be limited to English language. Then they wrote that mesh terms. This is the best, and we can find this in method section. Okay, in our paper on the right, they search the author search Medline, PubMed, Scopus, Web of Science, Cochrane collaboration by experienced librarian, and this is good. They search clinical trial gov and WHO for grade literature or unregistered trials. Then they did manual searching, and they did the manual searching in the citation references. The search strategy by keywords. The keywords included canine, cusp, etc. Okay, this is good. Then our answer is yes. The third question, were the criteria used to select articles from inclusion appropriate? The best is the eligibility criteria used should be specify the patient's intervention or exposure and outcome, like BICO question. Uh, where I can find this in method section. This is wrote there in method section. Okay, and the answer is yes, apart from the control group. Where the included study sufficiently varied for type of question asked. What is the best quality of each study was assessed, and this is using quality criteria appropriate. The type of clinical question, randomization, blinding, we can find this in the method sections. The author wrote in the method section that the article met inclusion and exclusion criteria were read fully and evaluated for that quality based on methodological quality criteria, table 3. In the table 3, they had a tool for with total score of 11 to assess the studies. In the table of the methodological quality, they assessed the Naumova et al. 2015 study as a good quality evidence, Bazarkani et al. 2014 as a good quality study. I don't know why they used risk-based tool, other risk-based tool, apart from the quality. They assessed the concealment of randomization, the stop early, the blinding of patient or the operator, the blinding of the data assessors. T question, were the results similar from study to study? In other words, are the studies similar or homogeneous? We can measure that by chi-square test or I-square to know if the studies are homogeneous or not. But this is the statistical homogeneity. And we should assess the methodology to know the clinical homogeneity. If the studies are similar in the inclusion criteria, exclusion criteria, in the outcome, in the results, in everything. Okay, I will go through the other systematic review. the systematic review by Parkin. The first question, what question Pico did the systematic review address? There is, I think, more detail here in this systematic review because this Cochrane systematic review, types of studies, randomized, types of participant between 10 to 12 years of age, with badly displaced maxillary canines, type of intervention extraction of primary canines, compared to either no treatment, delayed treatment, or an alternative treatment. In the previous systematic review, they didn't try that. There is no treatment or comparison group. And the type of outcome measurements, the primary outcome is the prevalence of eruption of or non-eruption of the permanent canine. In the secondary outcome, the improvement in vertical position, everything else. And I think the answer here is yes. For the second question, relevant study were missed. I think they did the comprehensive research. The electronic search was done and the compressed Cochrane Central Register, midline, embase, uh, Cochrane Health Group, the appendix of the search strategy, the mesh words, Boolean operators, everything is comprehensive search. It was a comprehensive search. And the answer is yes. There is no missed papers. The criteria, the inclusion studies, they have clear criteria to select studies, randomize, clinical trial, extraction of primary canine, of primary maxillary canine. The validity of studies, they assess the studies by the risk of bias in the included study by the risk of bias tool in Cochrane study, and is a good tool to assessment of risk of bias in the included studies. And I think the answer is yes. Were the results similar from study to study? They have a good plan for the heterogeneity, the statistical heterogeneity, uh, the I square statistic or test, and they did a good plan. If the I square is 0 to 40%, the heterogeneity will not be important. And if the statistical heterogeneity or I square is more than that, there is substantial heterogeneity. And this is good statistical analysis, but statistical plan. But we should concentrate on the clinical homogeneity. We should assess the study, the included study, if they have the same methodology, the same inclusion criteria, and the same results, the same everything in the study. The studies should be similar in the in clinically in the intervention. As here, all studies extract extracted the primary canine, the upper primary canine, and this is similarity between studies. So that apart from the statistical heterogeneity, I think the studies are homogeneous clinically. Okay, finally, what were the results? This is meta-analysis. In meta-analysis, we have two models, fixed effect model and random effect models. If there is heterogeneity between studies, we should use random effect models because the studies are different, are not similar. We will see for every study the ID of the study on the left. Then we will see that those lines or forced plot. In the forced plot, we can see this uh, rectangular, okay? And if the rectangular is large, then the effect size is good, like this. The weight is good and the effect size is good or large, like this study. If we have a small rectangular, then the weight is small and the effect size is small. This line, the horizontal line, is the confidence interval. If the confidence interval or the line is small, then the study have a good confidence, and we are more have more precision in the study. But if the study have a long confidence interval, then we are less precision in this study. The diamond in the last of this plot is uh, the pooled estimate of the all studies, like here. On the right, we can see that test of heterogeneity, chi-square, and DF p-value, and the test of overall effect, p-value here is less than 0.00001, and this is statistically significant. The vertical line is the line of no effect, and on the right, the favors control, on the left is favors treatment. Okay, we're still here in the appraise, in the third step, appraise, and the applicability. If if I'm willing to apply the results, I should see the inclusion criteria or see the characteristics of studies. Naumovo et al. And Bazargani et al. Those studies are the highest quality studies in the systematic review. The boys and girls are here in this study, and the age is between 10 to 12. In the Bazargani, the age is between 10 to 14. And I have more girls and more boys in this study than the first study. The results: the eruption of the canine, the palatally displaced canine, in the extraction group in Naumova study, okay, Naumova study is 69%, but the eruption of palatally displaced canine in control group is 39%. Okay, to know more than that, I should go to the relative risk. Relative risk is the incidence ratio between exposed group to non-exposed group. Okay, here the exposed group is the extraction group and the non-exposed group is the control group. The risk ratio here is 1.7, which means in 1.7 the canine will emerge in the extraction group more than the control group. This is the simple interpretation. Also, to be more precision, we can calculate the risk difference. The risk difference, we can subtract the control group rate from the exposed group rate or the extraction group rate, and the result is 30% of the risk difference. Now I can calculate the number needed to treat. Number needed to treat is the number of patients you need to treat to prevent one additional bad outcome. And in our example, an additional bad outcome like impaction. The number needed to treat here is 1 divided by the risk difference, 1 divided by 0.3, which means 3.33, and 4 patient. we should extract 4 patients or 4 canines to prevent one additional impaction. This is the interpretation of this study. Okay, to apply this evidence, because I appraise the evidence, I have two studies, two high quality studies or two good studies, two good quality studies, and the good quality studies said that I should extract four canine to prevent one additional impaction or one additional impacted canine. In our MOVA study, we can go to the eligibility criteria and the conclusion to say that with this rate, with mean eruption time, the mean eruption time is 15.6 plus minus 5.6 months in the extraction group and 18.8 5 minus plus minus 5.8 months in control group. That means if I extract the canine for this girl, for this 13 girl, I should wait between 10 to 20 months without doing anything, just waiting for eruption of the canine. And I should discuss this with the girl and with her family, if they accept that or not, to decide uh, or to make a decision for this treatment. The generalization in this study that Caucasian population aged 10 to 12 years in the case of exclusion criteria are met, the use of imputation values are mentioned above. Analyze and adjust. If I apply this evidence in my practice, I will observe the results. Then I will adjust my practice according to my patient preferences, to my findings, my own findings based on this evidence. Okay, the question now, can I apply this evidence or those evidence on the right side, on the buccally displaced canine? In my own opinion, uh, no, we cannot apply the finding of those systematic reviews on the right side because I think there is other factors can help this canine to get back in its position. I will cover now a minor topic, the surgical adjunct acceleration. I will discuss some evidence about the acceleration. This is a study by Fleming, done by Fleming on 2019 in Cochrane Library. This is systematic review, and in their meta-analysis, uh, they found that the effect size is 0.61 per month acceleration in the adjunct surgery group with and this is statistically significant, p-value is less than 0.0001. But this effect, or yes, this effect is transient for 3 months, which means that in the 3 month we can have 2 millimeters uh, in the surgical side or in the surgical group more than the conventional treatment group, and this is statistically significant. But this is the all acceleration because the acceleration is transient for 3 months. This is randomized controlled trial published in European Journal. The researchers found that the overall treatment time was significantly lower in the test group in the position group uh, 278, then the control group 393, and the physician assisted treatment was 1.6 times faster than the conventional procedure. Okay, we can calculate that if we divide 393 divided by 278, and the result is 1.4. If we calculate the acceleration, uh, the authors wrote in the conclusion that the acceleration is 36% reduction in treatment time, and we can calculate that 393 subtract 278, and the all on divided by 393, and the result is 0.29. Then the reduction in the treatment time is 0 or 29%. This other randomized controlled trial published in European Journal, and the authors wrote that the experimental group required less mean treatment time, 53 days versus 131. If we looked at their data or their tables, we will find that the regularity index in the control group was 11.32, and the experimental group was 11.57 in the beginning of the treatment. After 1 month, there was a high reduction in the experimental group. The result is 4.1 millimeter, while in the control group 8.5. Okay, in the second month, LL2, in the second month the control group was 5.56, and the experimental group there is remaining irregularity index or remaining crowding in this group. There is 2.75, and this number need additional month to resolve. This crowding need additional 1 month. How they calculate that? By 53 days. If here 1 month, 2 months means 60 days, and at the 60 days they had 2.78, it's 75, and they needed one additional month to resolve this crowding, and I don't know how they calculate that by 53 days. Okay, thank you for listening.